You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome all. My name is Jay Parekh. I'm an ophthalmologist in northern New Jersey, and I'm also Chief Commercial Officer at Nordic Pharma. And I'm thrilled today to have two of my very esteemed colleagues and friends for decades, actually, Dr. Darrell White and Phil Gioia. You can briefly introduce yourselves. Darrell, your practice.
Sure. My name's Darrell White. I'm a cataract and refractive surgeon. I practice just west of Cleveland, Ohio. And I've had a really strong, deep interest in all things dry eye for goodness going on 25 years now. And it's been a real kind of anchoring point for my practice and really comes into play with everything I do, especially with the cataract and refractive surgery.
Introduce yourself at Nordic Pharma, what you do, and why you're so excited about Nordic.
Thanks, Jay. Yeah, I'm Phil Gioia. I'm president of Nordic Pharma and joined about 2 years ago, and had the good fortune to start an ophthalmology business here for Nordic Pharma. European-based, but looking to really expand and start a business in the United States. We need other treatment alternatives for our dry eye patients. And LACRIFILL, check that box off for me right out of the gate. And I'll just hit a few points and then turn it back to you. But the first thing I see is device, not a drug, 510K. LACRIFILL is a 510K device approved for symptoms of dry eye disease. And it comes in a syringe with 98% water and 2% cross-linked hyaluronic acid. So immediately I'm thinking, well, it must be safe. And hyaluronic acid is so present in our current world and the aesthetic market and other places. So I'm checking that box. And then number two was approved. The product was already approved and was getting through just a series of deal considerations. And then it lasts for 6 months. And it's reimbursed with an established CPT code. So I think about the physician, the patient. I'm representing a company, and it just checked those boxes off for me, and that started the initial journey.
So you just heard Phil's pitch. Let's just be real time, right? You've been involved with us minus 30 days. You heard Phil's pitch about the attributes, the story. It's a really cool story. What gets you excited about hearing Phil's pitch? And in real time, now 9 months, 10 months later,
The people who established Visant actually approached me almost a year before they went into this bidding process and presented me with LACRIFILL, showed me the data, told me about the history, and said, what do you think? And I was instantly taken by the potential, totally excited about it, and offered my assistance. And then for me, they kind of went dark. And really the reason for that was they hadn't been in a position yet for true commercialization.
Right.
And there was nothing for me to do. It's such a great idea. And when I heard that Phil and Nordic were participating, when I found out that you were the chief commercial officer, it was a no-brainer. I was waiting for the call. I honestly don't remember who called whom. But I remember that when we actually had the call, I was very, very excited about it, because here we had something which was going to be unique, something which had all the attributes that Phil just laid out, but something that was going to fill a void in the things that you and I do. And the beauty of this particular product is that it's not a one-trick pony. It's not just a dry eye medicine. It's not just a perioperative medicine. It sits at that intersection between everything that we do. And I'm sure we'll get a chance to talk about it, but part of the thing that it does is it fills a niche for us. Increased contact time with the natural tears, increased contact time with the things that we want to have on the surface of the eye. But it doesn't come with any of the pitfalls for all the prior technology, such as it was, that was available. So, heard about it beforehand, kind of bummed that it kind of lost me, if you will. Super psyched to hear that it was you two who were involved. and then was ready. Was ready when the phone rang, or maybe Phil was ready when I rang him, but was ready to participate because it's something that has a place. And interestingly and fascinatingly and wonderfully, it already had champions. So once again, you didn't really need me. I'm happy to be in for the ride, but this was a product which deserved you guys, and you guys have really done a lovely job with it.
What excited you through the journey of the last 9 months until today?
There are two ways that I'm using this in my practice. We have a huge standalone dry eye practice. I'm very often the 5th or the 13th or the 29th consult for somebody with dryness. And you see really, really basic things that could have been taken care of. I mean, what's more basic than aqueous deficient dry eye? It's so easy to understand. It's like the Gobi Desert. Why is the desert dry? There's no water. Why is the eye dry? There's no tear volume. For years, we've tried to plug the tear ducts with little plastic or silicone plugs, and not a one of them was even adequate, really. It's not that they weren't perfect. It's that they all had near fatal flaws. They fell out. That was the big thing.
That's right.
Patient comes in, they wait for you, you put the plug in, everybody's all excited. A week later, it's gone. Or they don't know it's gone, and 6 weeks later, they come in and say, how you feeling? Yeah, doc, not a whole lot different. And the plug is gone. Or even more maddeningly, they come in and there's fibrosis, there's an infection, they've got inflammation, it's rubbing against the eye, and what you did to make them feel better actually did quite the opposite. The beauty for LACRIFILL for me is that whether I'm trying to optimize the ocular surface for my cataract or refractive surgery patients, or if this is just a 17th consult, and they're coming in, and that one really, really simple thing, which so often is the thing that's missing, is there to be taken care of. LACRIFILL is something that I can do right then.
That's right.
I can do it right then. It doesn't hurt. As soon as you put the LACRIFILL into the one punctum and occlude the left eye, for example, the patient instantly relaxes. Now, of course, they're a little uptight the first time you do it because they don't know what you're going to do.
That's right.
Is it going to hurt? Do I need to be asleep? And then the second one, your biggest problem, my biggest problem is, because most of my patients are just as chatty as I am, they won't stop talking. Oh, that was so good. I mean, you got to stop. Don't. That's my biggest challenge. Not really that bad a challenge. It's the instant ability to rectify a basic problem from a dry eye standpoint. But then from the cataract and refractive surgery standpoint, you really don't want anything that you really need to do to have any slowdown effect. You don't want to be tapping the brakes in your normal procedural setup, not only for you, but also for the patient. They come in, they've decided that they're going to put their eyesight in your hands, and they're going to have LASIK, or they're going to have SMILE, or they're going to have an EVO. And these are things that they can take care of with contact lenses or glasses, so it's not even like a cataract. And they're ready. And they don't want to stop.
That's right.
They don't want to slow the roll. LACRIFILL allows me to do the best medicine possible in a way that makes it convenient for the patient and neither disrupts their expected process nor puts even a speed bump in our typical process when we're doing surgical training, surgical planning.
Right.
And it was exactly what we needed and wanted. It just hadn't been there.
That's right. So you talked about a lot of things. I'm very passionate about everything you said. Dry eye, cataract surgery, refractive, the importance of the ocular surface around the journey of those patients that are undergoing those procedures. But the labeling here is really cool. It's incredibly broad. And Phil, maybe talk to us about how important when you're launching a product, the label is, right? Darrell and I could be innovators. Darrell and I can be the champions for patients. But if they don't have access or a proper code to cover what we're doing, then you're sort of outside the payer matrix. And in eye care, we talk about being outside the payer matrix. We're actually inside it, right? Whether it's glaucoma or retinal diseases or cataract surgery. So Phil, talk to us about how important a label is when you're launching a product.
It always comes back to you and your patients. And it was, LACRIFILL was the product that's time has come. It's a new innovation, easy to administer, all the points that you raise. And I just love hearing now, as we've launched the product, hearing from physicians who are using LACRIFILL and how it's part of your treatment algorithm.
Yeah, and to Jay's point about the label, sometimes the label becomes an impediment because not all of us are quite as comfortable going off label.
That's right.
And the label that you guys were able to achieve gives us a lot of leeway, a really, really lot of runway in order to be able to do things and be perfectly within the rails of the label.
100%. And so it's a blessing and a curse as a marketer when you have a label so great as LACRIFILL, symptoms of dry eye disease, device. So, we get to play with that label, which is broad in everyone. And for us at Nordic Pharma, we were building. So Jay came aboard as chief commercial officer. We were hiring an infrastructure, sales and marketing while we're preparing for a launch because we have a product that's approved and we want to get this to the market as quickly as possible. And so with a small sales force to start, where we really focused on was that pre-op cataract patient as one example, to find a space where we could find a home to start. Keep it centered so when we're talking, our field force is talking to you or other physicians, optometrists, MDs, they can see where the potential is to at least start to use LACRIFILL. But now, here we are at our second ASCRS meeting. Everything's changed from, we were just talking about, as we were walking in, our new booth. We were like I was joking with Jay as we were driving over here, we're like the little engine that could. I love punching above my weight class. And I know both of you share that kind of descriptor as a competitor and trying to be best at what we do for a living. Oh, so we had, it was months of just development and work and it was exciting. I just paused, we had an opportunity to go in and see and going back to where we started not even a year ago and now to see the infrastructure build, the product messaging relate to what you do with how you treat your patients. And now we move to that label of symptoms of dry eye disease. So that's the part that's exciting.
Many of us have done punctal plugs. Some of us still do punctal plugs. A lot of folks just equate that with almost a generic way of treating a patient in an interventional way, right? They fall out, they can cause granulomas, they can sometimes cause infection. Sizing can be an issue. Not every puncta is the same. Even the same patient, they could not be identical sometimes. But now we've changed the vernacular, right? We're not creating a new category per se, but we've changed the vernacular, Darrell, from punctal occlusion to lacrimal occlusion. And you've helped us shape that. Thank you so much. So what does that mean, not only to you, but to the audience that may want to adopt this technology and start implementing lacrimal occlusion as a way of taking care of their dry eye patients?
It's fundamentally what it means is that we are now doing something which is frankly more physiologic.
Right.
We're not just putting a cap. I thought of punctal plugs, or think of punctal plugs, as kind of like the manhole cover on the manhole. Right? Water can still get in. If they're a little askew, if something happens, they can be bumped, and then that becomes an impediment rather than something which is helpful. But if you fill the system, if you have a significant part of the system filled, then all of those things that are just about occlusion are rendered moot.
Right.
But you're still getting exactly what we want. We're getting a greater residence time of medication, a greater residence time of natural tears. If you use artificial tears, you're getting a greater residence time on the ocular surface. And it's almost like the analogy that I use with patients. It's almost as if the eye has a single faucet and two drains, no longer a plug, but a drain.
That's right.
And if you fill the drain up, the water is going to stay on the surface of the sink for a longer period of time. But you're going to have a more effective fill because it's not just a cap. And in reality, in one of those beautiful things where the poetry meets the prose,
Right.
the words actually mean exactly the same as what we're doing from the function.
Yeah. And that's resonated truly in all of eye care, in the last several months. And for sure in optometry as well as ophthalmology. And the ability for optometrists to be able to do this as well as ophthalmology, there's going to be a shortage of eye care doctors the next 4, 5, 6 years. So it's all of us together taking care of the patient in the myriad ways we can. So I can go on for hours and talk about dry eye and innovation. The two of you have been wonderful. You inspire me, Phil on the corporate side, and obviously Darrell as my friend and colleague as we help companies get from here to there. So thank you.
My pleasure,
Thank you,
Jay.
Jay.
Pleasure to be here with you.